So good morning, good afternoon, everybody. It's a real pleasure to be here today for this new IITH journal clubs. We have the pleasure to have two great speakers today. We have Dr. Vera Radici, which is an hematologist. She's working in Italy, and she's going to present us a very interesting report of a patient that developed myelodysplastic syndromes after treatment for lymphoma. And as an expert, we have Professor Thomas Cluzeau, who is working in Nice, in France. So please, Dr. Radici, you can share your screen and we can start. Thank you.
First of all, thank you very much for inviting me to this interesting journal club. Thanks, Professor Mallard. Let me introduce a case of a high-risk myelodysplastic syndrome following CAR T-cell therapy in a patient with relapsed diffuse large B-cell lymphoma. I have no disclosures. In August 2019, a 57-year-old woman with a previous history with diabetes mellitus and obesity was diagnosed with germinal center diffuse large B-cell lymphoma. At diagnosis, she presented cervical lymphadenopathies, spleen involvement with a staging of an Arbor stage 4SA. A bone marrow biopsy revealed a 25% infiltrate of lymphocytes in a context of normal hematopoiesis. She was classified with age-adjusted nervous system IPI high-risk score. The patient was treated with 4 cycles of rituximab, adriamycin, vincristine, prednisolone, and associated with intrathecal chemoprophylaxis, obtaining a complete response. After that, she received a consolidation chemotherapy with 1 cycle of rituximab, mitoxantrone, cytarabine, and dexamethasone, following by 1 course of high-dose cytarabine with stem cell collection. In April 2020, autologous stem cell transplantation was performed using fotemastin, etoposide, cytarabine, and melphalan as conditioning regimen, achieving a complete metabolic remission. After she had the maintenance therapy with rituximab. Unfortunately, in December 2020, she relapsed with the supra and subdiaphragmatic adenopathy, liver lesions, and uterine lesions. A bone marrow biopsy was performed, and no signs of lymphoma infiltration or dysplasia were found. The patient was considered eligible for CAR T-cell treatment. She underwent lymphocytes apheresis, following by 2 courses of rituximab, etoposide, cisplatin, cytarabine, and methylprednisolone. On the first day of standard lymphodepletion, the blood test shown grade 2 anemia, grade 2 leukopenia, and grade 1 thrombocytopenia, according to the common terminology criteria for adverse events. Tisacel infusion was administered on April 2021. The patient did not develop cytokine release syndrome or ICANS, but only 1 episode of fever caused by Staphylococcus hemolyticus. 2 months after CAR T-cell therapy, the patient was in complete remission, and the bone marrow biopsy showed normal cellularity without dysplastic features or cytogenetic alterations. In the following months, the blood count showed a progressive normalization of white blood cell values with hemoglobin ranging between 8.5 and 10.4 gram per deciliter and platelets between 20 and 40,000. 7 months after T cell infusion, the cytopenia worsened with grade 3 anemia, grade 3 leukopenia, and grade 4 thrombocytopenia, requiring recombinant granulocyte colony stimulating factor and erythrocyte and platelet support, as you can see in the picture. In December 2021, pancytopenia persisted and the patient remained in complete remission. A bone marrow biopsy ruled out lymphoma infiltration, but revealed a multi-agent dysplasia without excess of blast associated with the chromosome 7 deletion. In this slide, you can see some images of bone marrow biopsy. After all, a diagnosis of a high-risk revised IPSS was performed, including multi-agent dysplasia without excess of blast associated with the chromosome 7 deletion. The patient received 3 cycles of azacitidine, obtaining a complete remission. And after that, she had an haploidentical stem cell transplantation. Uni and multi-lineage cytopenias are increasingly recognized as a side effect after CAR T-cell therapy. And while early cytopenia after CAR T infusion seems to be related to the myelotoxic effect of lymphodepletion, the development of late cytopenia has a multifactorial origin, and it remains poorly understood. Some authors have shown that baseline cytopenia, elevated baseline levels of C-reactive protein and ferritin were correlated with the duration of neutropenia after CAR T-cell. On the right, you can see the CAR hematotox score parameters. It is a score capable to identify patients at high risk of developing cytopenia after CAR T-cell therapy. In our patient, the CAR hematotox score was low, determined only by a high level of ferritin. Therefore, in order to explain the worsening of cytopenia, a bone marrow biopsy was performed and an high-risk myelodysplastic syndrome diagnosis was made. And the deletion of chromosome 7, we know that is one of the hallmark features of a therapy-related myelodysplastic syndrome. Secondary MDS following autologous stem cell transplantation has an estimated incidence between 5 and 20%. Our patient was treated with both alkylating agents and topoisomerase II inhibitors before CAR T-cell treatment. Therefore, she was at increased risk to developing MDS related to the mutagenic effect of previous chemotherapy. At the same time, we cannot exclude the fact that the CAR T-cell treatment can play a role in the development of the MDS. Recently, an interesting case of diagnosis of acute myeloid leukemia, which developed 2 months after CAR T-cell therapy for DLBCL, was described by Professor Follonig et al. On the top of AML diagnosis, next-generation sequencing detected the mutation of the following genes: DMT3A, RANX1, N136K, and PPM1D. Bone marrow sample taken before CAR T-cell treatment showed the DNMT3A and the PPM1D mutations, but not RANX1. So this patient had a clonal hematopoiesis driven by DNMT3A already present at the time of DLBCL diagnosis. and the acquisition of RANX1 2 months following CAR T-cell promoted the evolution to acute myeloid leukemia, probably through cooperation with the deletion of chromosome 7. In our case, the NGS performed on medullary sample 8 months later after CAR T-cell therapy identified the mutation of CSF3R, CEBPA, and RANX1. When we retrospectively performed the NGS analysis on a cryopreserved sample collected during the harvest of blood stem cells before autologous stem cell transplantation, CSF3R and CEBPA were found. CSF3R gene lesions are uncommon in myelodysplastic syndrome, occurring with a rate of 3%. They are an age-independent and IPSS-R-independent risk factor for leukemia-free survival. In a male setting, CSF3R are frequently associated with abnormalities of RANX1, CBFB, CBPA, and NPM1. Conversely, in MDS setting, RANX1 mutation occur in 8–23% of MDS, especially in therapy-related MDS. They are frequently detected in patients who develop AML with a negative impact on survival. In our case, the patient had a dominant clone with CSF3R mutation and the subclone of CEBPA lesions before autologous stem cell transplantation. Considering consistent variant allele fraction without fluctuation over time, CSF3R mutation is likely to be of a germline origin, while the CEBPA lesion, we can consider them belonging to clonal hematopoiesis. 8 months after CAR T-cell, the cytopenia worsened dramatically, and the bone marrow biopsy revealed the deletion of chromosome 7 and the onset of RANX1 mutation. Subsequently, we can say that the acquisition of the deletion of chromosome 7 and RANX1 mutation promoted the development of myelodysplastic syndrome. In conclusion, this is the first case report of high-risk myelodysplastic syndrome developing after CAR T cells, and in addition to the case described by Professor Follonig et al., the second one in which deletion of chromosome 7 and acquisition of RANX1 are reported. The coincidental recurrence of this genomic alteration could be occasional, and this would certainly appear to be a limitation of our case report. However, they may reveal a stepwise leukogenic evolution, starting from the presence of a pre-CAR T-cell clonal hematopoiesis trait. Here you can find some open questions, and the observation of these two case reports strongly suggests that NGS analysis for investigating the presence of clonal hematopoiesis before CAR T-cell therapy should be performed. For this reason, we have designed an observational multicenter prospective study called the Clona EMA CAR T study, with the aim to evaluate clonal hematopoiesis before CAR T-cell therapy and monitor its clonal evolution after CAR T-cell infusion, especially in the case of persistent cytopenia. So thank you very much for your attention.
So thank you very much, Dr. Radici, for this really nice presentation. So again, please send your question in the chat. We'll try our best to answer all the questions. Do not hesitate to answer any question you want. So I have a first question. I will start with you, Dr. Radici, and after I will go to Professor Cluzeau. Just because you say that this is myelodysplastic syndromes onset right after CAR T cells, do you think that if we did not perform CAR T cell, this patient would not have developed myelodysplastic syndrome, that we should not perform CAR T cell because patients are going to develop myelodysplastic syndrome? Is this what you say? Or do you think that we should perform things differently just to avoid this kind of things?
Thank you, Professor Malard, for this interesting and difficult question. Among the possibly causes of persistent cytopenia and the development of myelodysplastic syndrome, I think that we have to think about the previous history of this patient of chemotherapy and also of an autologous stem cell transplantation. We can't forget also the significant impairment of immunosurveillance related to the disease and after also to the CAR T cell treatment. So I think that we have to understand the role of CAR T cells in developing secondary myeloid malignancies, and I think that maybe in the next few years we can also try to understand the role of genotoxic damage related to previous chemo and radiotherapy in this setting of patients.
Professor Cluzeau, what is your opinion regarding that question?
So thank you for the presentation. This is a really interesting case report. For me, I think this is a good point to discuss today, because today we have the approval or we can use CAR T cell earlier now in the treatment of lymphoma, and I think maybe we have to discuss what is the best time to propose CAR T cell therapy in the treatment of lymphoma. So as we know today, we could observe myelodysplastic syndrome or acute myeloid leukemia after auto stem cell transplantation, and we could also observe myelodysplastic syndrome or acute myeloid leukemia after several lines of chemo. So today, CAR T cell therapy is another line after several lines of treatment. So for me, maybe the immunosurveillance is the last point, maybe to accelerate the transformation in myelodysplastic syndrome or acute myeloid leukemia, but the disease is probably here before, as you shown. The mutation were already present before CAR T, and maybe yes, you have a burden of mutation after decrease of immunosurveillance. So this is my point of view, but I totally agree with your study to explore very well the clonal evolution before and after CAR T. But maybe one question: if you did the bone marrow evaluation before CAR T because the patient had cytopenia, and if you identified myelodysplastic syndrome at this time before CAR T cell therapy, did you continue the CAR T cell therapy or not? or did you decide maybe palliative care for these patients?
Thank you, Professor Cluzeau. Many questions to answer. First of all, after this case, and in general, after studying this kind of complication, because we know that hematological toxicity is an emerging as the most relevant long-term side effect after CAR T-cell. Also with this study that is ongoing, we performed bone marrow biopsy, especially in patients that has cytopenias, and also to try to understand if they have clonal hematopoiesis. If I find myelodysplastic syndrome in and the bone marrow biopsy before to decide, but I think that CAR T-cell is a very game changer in the treatment of this kind of hematological disease. So maybe we have to understand the impact of some mutation in the developing and in the worsening of cytopenias in these patients. So I could imagine that a bone marrow before CAR T-cell has some dysplastic features because of previous chemotherapy. So maybe it depends on the situation of the patient, on the general condition of the patient, and but maybe I would go for CAR T-cell.
Okay, thank you. And so, sorry, Florent.
Yeah, this is a good question. I think what we could propose, if we have this kind of patients, if the patient is fit, is to do the CAR T-cell and to start finding a donor just to perform allogeneic stem cell transplantation around 3 months after the CAR T-cells, if the patient is fit. But just go on.
Yeah, totally agree. And do you quantify the CAR T before allo and after allo stem cell transplantation?
Yes, I don't have exactly numbers, but after some months we didn't find any CAR T-cells, circulating CAR T-cells. So but the patient remained in complete remission. So it has a very low percentage of CAR T-cell, but the patient was in complete remission for her lymphoma before allogeneic stem cell transplantation.
Okay.
But it's a very good question, because it's also important that the lymphoma remain in remission, obviously.
And I have one question. It is maybe for you, Professor Cluzeau, because you ask what we do if we find myelodysplastic syndromes, but if we just have some clonal hematopoiesis, do you have a particular monitoring in this case?
So if we identify only clonal hematopoiesis, I think, I guess it's not a contraindication of CAR T, of course, but I would recommend to follow the clonal evolution after CAR T, of course, and maybe perform bone marrow evaluation, subsequent bone marrow evaluation, maybe 1 month after, maybe 3 months after, and after maybe depending of the cytopenia. But this is a really good question. I think it's not the same follow-up depending of the type of the mutation. Of course, if we observe a TP53 mutation, I think we have to do what you said, Florent, to perform maybe 3 months after allo stem cell transplantation very fast, because we know if there is a TP53 mutation, we have a high risk of therapy-related myeloid neoplasm. If it's only TET2 DNMT3A, it's difficult because we don't know the delay to have the therapy related or say secondary myelodysplastic syndrome or acute myeloid leukemia. So it's difficult to say if we have to perform an allo stem cell transplantation very fast or not. So it's why for example, in this kind of patient, I would recommend a short monitoring, but not maybe another aggressive treatment like allo too much early. I don't know. Why do you think, Florent? Yeah.
I will do the same thing. I will do a close monitoring, look at the cytopenia very closely, but it's difficult to perform transplant if we just have some clonal hematopoiesis, maybe except for the TP53, of course. Regarding the treatment they perform for the myelodysplastic syndrome, so Dr. Radici uses azacitidine. Was there other option you discussed at that point?
Yes, it was a difficult decision, but in our institution, azacitidine and hypomethylating agents are the first line of treatment in a myelodysplastic syndrome. So the patient had 3 cycles of azacitidine, obtaining a complete remission, also cytogenetic remission. So she had a good condition to go to allogeneic stem cell transplantation. So I think it was a good option. Maybe we have to we need more studies to investigate also therapy in this kind of patients, because maybe I don't know if the add of for example venetoclax could help our patient to modify something or not at the clonal hematopoiesis level. So and also maybe we have to investigate eventually allogeneic stem cell transplantation.
And so, Professor Cluzeau, if you have the same patient, you will have to do azacitidine, aza plus venetoclax or something else?
I think it depends where you are, in which country you are. So of course, it depends which treatment is.
In an ideal world, any treatment are available. You can do everything you want.
So yeah, so I think today there is maybe 4 choice we could challenge. We could challenge an allo stem cell transplantation frontline because there is no excess of blasts. So maybe we could undergo directly to allo stem cell transplantation. We could do azacitidine as you did. We could discuss maybe azacitidine plus venetoclax. As you know, we are waiting the results of the phase 3 clinical trial, the Vera clinical trial. We hope to have the results of this phase 3 maybe at the ASCO or the ASH meeting, next ASCO or next ASH meeting. And we are also rating the results of the phase 3 clinical trial ENHANCE, comparing azacitidine plus magrolimab versus azacitidine alone. And we hope to have also the results maybe for the next ASH meeting. So I think we have these 4 options. we don't know today for the azacitidine plus venetoclax or azacitidine plus magrolimab if it's better. Of course, we have the results of the phase 2 clinical trial. We know we increase the complete remission rate after this treatment. So it's really interesting in bridge to transplant, because we know with this two combined therapy, AZA plus venetoclax or AZA plus magrolimab, we obtain more CR, marrow CR, and maybe deeper CR before allo stem cell transplantation. So it's better to obtain longer survival after allo stem cell transplantation. So in practice, if I have something to do, I think if I could add another drug to azacitidine, maybe I will do that.
Yeah, so yeah, a lot of possibility, of course. Yes, allo frontline is also an option if you don't have any drugs available, and sometimes this is easier. So this is some case, and there is no good answer. And at the end, when you perform AZA plus allo, it seems to be successful for the patient. So it was great. Dr. Radici, I have one question in the chat. They ask if there is some biological material that remain. Is it possible to perform some dynamic whole genome sequencing to understand better? I don't know if you plan to perform some more things, or you are just now more focusing on your new observational study?
Okay, I'm just reading the questions. We didn't have information about genetic damage. We just have the data about cytogenetics on deletion of chromosome 7. And the other question, yes, about the biologic material remains, because we performed retrospectively MDS on a bone marrow sample, cryopreserved. So if you have any material, you can perform. Also, it's better to have fresh material, but sometimes we could use cryopreserved samples. And are there other questions?
No, yeah, it was good for the question. So I think we go through all the question. I just check if there's some new one now. So yes, there is a question regarding myeloma, and I was going to the myeloma, but right before there is one people that ask about CPX351. So this is just I missed the name, but Professor Cluzeau, you know what I am talking about. Do you think this is something that could be used?
Yeah, so today, as you know, CPX351 is only approved for acute myeloid leukemia, so therapy-related or MRC acute myeloid leukemia. So with the French group of myelodysplasia, Pierre Peterlin performed a clinical trial evaluating the CPX351 in myelodysplastic syndrome. In this clinical trial, we show that we observe a big complete remission rate. So it seems to be with a good safety. So it seems to be maybe a good strategy before allo stem cell transplantation. But today it's not approved. So it's difficult to recommend this treatment, but it seems to be maybe a good idea.
Yeah, and we have another question from Dr. Chen that asks for patients with myeloma, because we are using more and more CAR T-cell now for patients with myeloma, and we already know that patients with myeloma are highly pre-treated when we perform the CAR T-cells, and it's already happen that they receive also autologous transplantation, they receive high-dose chemotherapy, and we already have some patients with myeloma without the CAR T cell that develop some myelodysplastic syndromes and acute myeloid leukemia. So, of course, we'll need to generate some more data regarding if we see an increase because of immunodeficiency after the CAR T cell, if we see more myelodysplastic syndrome, and it would be very interesting to monitor them very similarly to what we are doing. Dr. Radici, I don't know if you plan to include also multiple myeloma. But the specific question from Dr. Chen is that a patient that have myeloma, but that also have pancreas cancers 5 years before the myeloma. Do you think you can perform the CAR T cells, or because of the immunodeficiency after the CAR T cell, we should just avoid it? I don't know, what do you think about that, Dr. Radici?
I think that it's important to understand the previous lines of therapy, how many and which kind of therapy the patient did before, and it depends if we want to have a remission before CAR T cell or not, or it's difficult to answer because.
But just, do you think that a cancer, the solid tumors 5 years before, is an issue or not? It's complete response.
If it's in if it's stable, and it's difficult to answer. Maybe yes. I think that it's an important issue to
yeah, I think if the patient it's in complete response for 5 years now, according to the OMS, the patient is considered as being cured. Whereas 5 years after, I think we can go for the CAR T cell.
In complete response, I think that you can go. Some patients have CAR T cell with previous cancer, solid cancer, and so maybe you can decide to have a radiological control or something like that, and decide to go with CAR T cell because you need to treat myeloma in that moment.
Okay.
I think maybe we have to use the same guidelines using for allo stem cell transplantation, because after allo stem cell transplantation, we know there is also immunosuppression during several months, and we could have an increase of another cancer. So maybe we just have to evaluate the balance benefit risk for relapse against the benefit of the CAR T, and maybe it's what we have to do. Of course, for the pancreatic cancer, I think if the patient is still alive after 5 years, maybe we have to do the CAR T. But for allo stem cell transplantation, we have this kind of discussion frequently to know what is the risk of relapse for this patient with a prostate cancer or with a breast cancer, and we have this kind of discussion. So I think we have to discuss for the CAR T like we did for allo stem cell transplantation.
Yeah, that's a very good point. So we are coming to the end of this great junior club. So I don't know, Dr. Radici, if you have a last comment.
I just want to say that also another point that I think could be interesting to understand is the role of T and B cell aplasia induced by lymphodepletion and CAR T cell, then that it remains to be clarified. And maybe also it could play a role in this setting.
Yes, there is still a lot of open question to know the interplay between the different things. And for you, Professor Cluzeau, last word?
Yeah, so for me it was a really interesting case, and so today we see there is only a few cases already presented about MDS EML post CAR T, but your study is really important to know the clonal evolution before and after CAR T, including immunomonitoring. So it's really really interesting, and we have a lot of to do.
So thank you again. It was a real pleasure to have you today for this amazing discussions, a very exciting topic. Merci